So, Lois, over to you to make a start.
Thanks, Sally, and welcome everyone. Nice to meet you all. So my name's Lois Beach, as Sally said. So I'm the Senior Research Officer at the HousingLIN, and I'm really looking forward to chairing this event. You know, in our working and personal lives, we're kind of all too used to hearing that the NHS is in crisis. So I'm really pleased that we and our brilliant speakers here today are able to provide some, solutions to the challenges that's faced by the National Health Service and those that use it. So we've got a range of speakers that are on the screen for you there. So we're going to start with Louis Worth, who's the Director of Care Research, who will review the key findings and recommendations from a report commissioned by Look Ahead, looking at kind of current services for young people who are experiencing mental health crisis, and it makes recommendations for new models of kind of specialist community-based services. We're then going to be joined and followed by kind of George Garrad, and who's the Associate Director of Health at Look Ahead, and we'll be joining, he's just joined us, so hello, Dr. Sheraz Ahmed, the Clinical Lead in Rehabilitation Psychiatry and a Consultant Psychiatrist, who will draw on some of Look Ahead's experiences of kind of running other services in partnership with the NHS. And then lastly, we'll hear from Karina Grimes, who's Deputy Director of Service Policy Design and Implementation at NHS England on the Proactive Care Programme. So it'd be really nice to kind of tie those three presentations together. So yeah, without further ado, I will hand over to Louis. Over to you, Louis.
Hi, everyone. Lovely to see you. It's great to be able to present that we did on behalf of Look Ahead and the Waits Family Enterprise Trust. The main aim of our research was to investigate the way in which external housing providers, non-NHS provision, can support young people, particularly those who are experiencing mental health challenge and difficulty. Let me just make sure I can share my screen full screen. Here we go. Joys of tech. Yeah. So, the context of the research. The main aim for our research was to review the main experiences and the views of young people, their families, carers, mental health
sorry
professionals.
to interrupt.
Oh, hello.
So sorry to interrupt. It's not widescreen. I wonder if it would be easier if I share on your behalf, just because the connection for me isn't great anyway.
No
would that
problem.
be easier?
Let's do that. That'd be great.
Yeah, great.
Thank you. Stop sharing my screen. There we go. There we go.
There we go. Is that okay for you?
Yeah, that's perfect.
Yeah, okay. Great. Thank you. Carry on.
To the first slide. No problem. Next slide. Perfect. So, the aim of the research was to review the experiences and views young people had in terms of their families, their carers, mental health professionals about the current system. We needed to raise awareness and influence national debate around the current challenges facing young people and their families experiencing mental health crisis. And we also wanted to contribute to a research-informed, community-based service for children and young people in mental health crisis. Apologies in terms of my background. I'm currently at a conference centre as part of some other work that I am doing. I did speak previously to the services about what we can do. Go on to the next slide, please, so I can speak more clearly. So, our initial work was to look at test-based research to identify the current gaps and the local approaches that were available. This meant interviewing professionals.
Sorry to interrupt you again. We've had a number of people mentioning about the sound being a challenge. Is it possible to try your headphones again, just to see if we can get that to work? Sorry to interrupt you.
Hello, can you hear me now? Is that any better? Hello, hello. Can you hear me?
Yeah, we can. I think that's a bit better. I can't hear the background. If you could just try speaking a bit louder than you might normally would, and irritating everybody in the costume that you're in.
That is fine. Can you hear me?
Yeah, that sounds good. Yeah, that sounds good. Thank you.
Excellent. Thank you. Apologies, everyone. Perfect. Thank you. So, we interviewed 22 participants across the NHS and health and social care sector. 10 participants interviewed with lived experience, including young people and their families. We did an independent ethics review to ensure that what we did was fair, was ethical, was safe. And we also did a short economic cost-benefit analysis of the value that alternative housing services can provide. Next slide. Just to give a little bit of the context that we are working in, what we can see here is the rates of detention per 100,000 under the Mental Health Act for those who are 15 and under, and for those who are aged 16 to 17. One of the things you'll notice is that the rate of community orders seems reasonably similar throughout both years. However, the rate of short-term orders drastically increases. This is because we're seeing that mental health services are having a greater pressure, particularly on police services, ambulance services, and other services to meet that need, partially due to the lack of provision and available support. Looking at the typical reference process, I'm seeing some other messages here, Lois. Not sure.
So I've noticed that there are some people that are struggling to hear you a bit, Louis. I think.
Do you want me to? If the sound really isn't working, I can try and do Louis' presentation. It won't be anything like as good as Louis', I'm afraid, but I did work very closely with him on it. So
thanks, George. That would be fab. I can hear you loud and clear.
I can have a stab at stepping in. What I would say, sorry, Louis, and thank you so much for coming. Is there still an echo on the line now?
I can't. It's all seems all fine at my end.
Louis, if you could turn your speaker off. No, okay, fine. All right, fine. Okay, right. What I would say to colleagues is, if there's anything that I don't cover off here or it's not as thorough as you might want it to be, I'm sure Louis and I can kind of answer on email together. But I wasn't expecting to have to do this, so let's see how it goes. But I'm sure I will do a reasonable job. As I say, I work closely with Louis on the development of this research that was kindly kind of commissioned along with the Waits Foundation. And we were, as an organisation, we at Look Ahead, we're mindful of the kinds of statistics that you can see on your screen now, but also equally mindful that we, so I'm still getting another comment about sound. Is it still an issue? Maybe everyone goes on mute apart from me.
Yeah.
But we were getting sort of significant feedback from the services that we run, the young people services that we run particularly, that we were getting referrals that we simply were having to turn away because the mental health needs were too high. So we had a kind of another interest from an organisational point of view to commission this work to try and better understand what was going on and potentially what we could do about it. What we saw, and one of the initial areas we were looking at was what the current trends were, and there's a kind of crude diagram there on the right hand side that explains what we found that was happening when people were in a crisis. If we flick onto the next slide, so the kind of primary areas of finding, the first one was around demand and access, and we reviewed numerous different social factors that were influencing people, young people particularly, accessing and requesting more access to mental health services. Lots of social factors that you won't be surprised at, ones that we've been aware of for many years in the kind of research sphere around sort of BME communities, people from LGBTQ+ backgrounds being a disproportionate influencer, but then also some more sort of new ones, I suppose, particularly around the influence of the pandemic and what that's done to increase referrals into services. The challenges of obtaining support that we found from interviewing various different clinical colleagues and people with lived experience were that and this one was particularly interesting, I think, that A&E was playing an accidental kind of front door role for accessing mental health services for young people. That's obviously not what A&E was necessarily established to do, and we found some really good examples of trusts that were trying to do things differently, but also many parents and many clinicians finding it very frustrating that that's what was happening in A&E, young people presenting in crisis because they didn't feel like they had anywhere else to go. Parents and young people particularly found the thresholds very high for accessing services, both sort of services at a primary care level, but also acute services too. And then there's this sort of perhaps less written about piece around the challenge that access was putting on parents. So it wasn't just young people that were children and young people that were experiencing poor mental health, but parents too. So if we flick onto the next slide. significant, and I don't want to spend too long on this because we want to get to the supported housing bit, but there were significant challenges around service delivery. Again, this won't be news to anyone who's picked up a newspaper in the last sort of year or two, but capacity staffing and waiting times were very high. There were big challenges and transitions in services. So what happens when a young person turns from 17 to 18, and that transition from CAMS into adult services was causing significant anxiety. And then finally, and probably most importantly for the purposes of this session today, there was a lack of alternatives to admission. We did find some really good bits of practice around the country, but they were very few and far between. There were some sort of off the ward, well, no, we found one example of an off the ward service to young people from CAMS wards. We found a little bit of sort of hospital in the community type models, but very, very little, and a lot of young people being placed out of borough, often very far away from their own home, often in sort of private healthcare that didn't work for them, didn't work for their parents, and didn't work for our colleagues within the NHS too. So if we flick onto the next slide. And so what were the potential solutions to admissions? What we did was we sort of posed this idea of a service that was run in the community in collaboration with our NHS colleagues, particularly CAMS colleagues and transitions colleagues, that would work with young people either to stop them from going on to wards in the first place, or taking young people who are medically fit for discharge but ultimately had nowhere to go off wards and into services. The idea would be that they would be run by organisations or third sector housing providers who had housing assets and had an infrastructure in place to provide support and care. So I don't, we did some economics as part of this. I would say economics in inverted commas, and actually when it comes to my next talk, you poor people are going to have to hear me speak twice, I'm afraid. I think it's important that we're cautious about these numbers. I think that an organisation like us can, or indeed others can, run services at a significantly reduced rate to our NHS colleagues for all sorts of reasons. But we need to be a bit careful about saying that's the primary driver for doing this. I think there's much more interest, and it will be really interesting to hear from Dr. Ahmed later around what his view on these sorts of things are. But where the answer to this stuff, I think, lies is in collaboration at a reduced cost to the public purse, but that not necessarily being the primary driver. But as I say, as part of this report, we did do some light touch number comparisons to what particularly I think is interesting is some of those unregulated mental health placements that we did find up quite a lot of, where young people were ending up rather than because there weren't space for them on wards, or indeed there was nowhere for them to go off of wards, ending up in often private providers providing unregulated mental health placements at a large cost to the public purse. So next slide. Recommendations. So the report made a host of different recommendations around the experiences of people in crisis care, which I probably won't go into too much detail now, but one of the primary ones was that we recommended the commissioning of new accommodation-based services that provided in-reach for young people at a time of mental health crisis. And then we thought that the really important factors that, or the kind of makeup of those services were that it should be delivered in collaboration with the NHS, supported housing and local authorities, each kind of bringing their own assets and their own strengths to the table, that it should be funded jointly, potentially using the new integrated care structures, and really importantly, that we have them located in geographies that work for young people and their families. So no more sending people who live in Tower Hamlets in London to Cornwall, or indeed people that live in Newcastle to Norfolk, that we're seeing quite a lot of, that we saw quite a lot of within the report. And that it should be sensitive to the age that the young person would need to leave, ideally kind of recognising the great work that NHS England colleagues have done in championing a kind of wider transition age up to the age of 25. Next slide is, I believe, if I remember correctly, additional recommendations around the report. Do you want to flick onto it? There were some additional recommendations that were made around improving practice within trusts, but I think we'll probably pause it there and move on to our next presentation, because that's more general. And then, sorry, there was just some quotes that that you can kind of read at your leisure. I'm sure these slides will be shared at the end of the session. That kind of both illustrate some of the challenges that we heard people talk about, parents, clinicians, but also some reflections that actually there is lots and lots of really impressive and encouraging practice out there too.
Fab, thanks George, brilliantly done. That's very seamless. So yeah, thanks very much for taking over. And obviously we'll be handing back over to you now to kind of provide a bit of a kind of example of what, where you're doing this already at Look Ahead and some of the benefits of providing those sort of preventative services. So I'll hand over to you and Dr. Shiraz as well. Thanks.
Maybe, Charlotte, no, I'll share my screen again then. Sorry. Let me just put it in presenting mode.
No worries. And yeah, others do please feel free to add questions as we go, and we'll kind of do a group kind of Q&A at the end. Any questions that we've kind of had that come through.
Sorry, I am not used to using Zoom and it's blocked the top of my slides, so I can't get into presenting mode.
I think there's an alternative way of doing it. If you go to the bottom right hand corner.
Yeah, that guy.
If you go to the left, yeah, that one, is that presenting mode?
Perfect, thank you. Yeah. Brilliant. Shiraz, would you like to introduce yourself? That would be lovely, and it will give people a break from my voice briefly as well.
Yeah, that absolutely. I'm Shiraz Ahmad. I'm a consultant psychiatrist working in rehabilitation in City and Hackney. And rehabilitation to us is basically people with chronic psychotic illnesses. So mainly schizophrenia, people that have spent a long time in hospital. And we do a lot of work in getting people out of hospital and finding the right supported accommodation setting. And I'm also doing a bit of work across Northeast London, which is looking at scoping out what the rehab needs are going to be over the next 5 years. And I think mental health support accommodation is a really big part of that. So it's lovely to be here.
Thank you. And so I'm George. This is what I thought I was going to be introducing myself. I'm the Assistant Director of Health Strategy at Look Ahead. And what that really means is that I work with colleagues from across the NHS and wider healthcare organisations to think about how an organisation like Look Ahead, we are a kind of charitable housing association that provides care and support to roughly sort of 4,000 people across London and the South East. We support people with learning disabilities, we support people, young people, homeless people, and we support people with mental health needs. And my job is threefold really, is to think about what the kind of research and evidence says that we should be doing in this space, what kind of innovative practice that we as an organisation could and should be pursuing, and then what partnerships do we need to be able to make a success of those types of things. And what we really wanted to talk to you about today is, exactly that. How can an organisation like us help the NHS and develop services for people away from hospital? And if we flick onto the next slide, because it's my slide, this is a really kind of crude analysis, but I think it's a nice way in, and I think it's a nice way in both in terms of us as an organisation looking externally, but also as a way of making our staff and working with our staff to think about, to let them think that they feel as though they're part of something big. Because I really believe we in supported housing are part of a bigger problem, and we're a massive potential part of the solution to some of the NHS's greatest challenges. I've nicked the Guardian and Independent headlines at the top there because they were examples of headlines that were generated off the back of the report that I just talked to you through. But we also, you don't have to try very hard these days to hear about some of the challenges that the NHS has faced. And Dr. Amma will know much better about these things than me, but I think it's interesting now when because people quite often don't really understand what the role of supported housing is generally and what role it plays. The way I've started to sort of talk about it, and the way we as an organisation are keen to continue to talk about it, is as a potential solution or part of the solution to some of these massive problems. So, ambulance call outs, ambulances struggling to get to patients in time. Well, we can play a role in supporting that. and I'll talk to you more about that in a second. Full wards, I don't know what the various wards across the areas in which colleagues on this call are at, but we know in London, for example, many of our mental health wards are operating at 110% capacity. Some are not, some are doing a brilliant job, but a lot of them are really, really struggling. We also have, a workforce that is very tired post-pandemic, and is potentially as a result of some of these challenges not being used in an optimal way. And again, I think we as an organisation and we as a sector can play a role in that. So really to set out some of those big challenges, I think it's full wards and supporting with challenges around admissions. I think it's busy ambulance and services, and I think it's workforce. So if we flick onto the next slide, it's me. So how do we do that at the minute? So the way we are increasingly thinking about the services we run is that they're preventative services. So they stop people from going into hospital in the first place. When we've taken people out of hospital and placed them in our services, again, we stop that readmission from occurring. And even when a readmission does occur, we're trying to consider whether or not being with us makes that length of stay that bit shorter. Very practically speaking, we run crisis houses. So we have 2 crisis houses in London, and what they do is prevent people from entering hospital in a mental health crisis. And rather than that, they come and stay in one of our services, which has significant clinical input from colleagues at East London Foundation Trust, but also specialist staffing teams as well that we employ. So we employ managers and specialist support workers 24/7, usually using double cover to support people in there. We also run hospital discharge services. So that's when people are medically fit for discharge. You'll hear NHS colleagues talk a lot about delayed transfer of care. So when people are medically fit for discharge, but actually have nowhere to go. So we work with various different trusts across London, particularly to take people out of hospital and place them in our services, often with a kind of slightly lower level of support than the crisis houses that I've just described, but supporting them to then either return to their own homes or finding them appropriate housing going on. We then run some even more specialist services that again perform a similar role, taking people away from sort of secure settings, particularly forensic settings, and hospitals with locked wards and into the community. We run, and actually that's that building there on the right hand side, a forensic mental health service in East London, again working with the East London Foundation Trust, that works with 19 people with a forensic history who've come out of long stay services and into ours. We found that those kinds of services are much more cost effective to run and better suited. So again, like, I'm mindful of time, so I've flown through that slightly, but three examples of how supported housing can take the pressure off the NHS. It can optimise the staffing, and it can kind of reduce costs to the system. But there's always like more to be done, and I've chosen 3 areas that I think are particularly relevant, and 2 of these certainly myself and Shiraz have spoken to at quite a lot of detail. So it'll be great to get his reflections on these in a second. The first one, and that slightly silly looking triangle in the middle is what's called a hierarchy of evidence. And my colleagues at Look are sick to death of me talking about this, but I will continue to talk about it because I think, being really blunt with you, the sector is pretty crap at evidencing the work it does. I think we are stuck at the bottom of the hierarchy of evidence with lots of case series and case reports and some editorials and opinions about the work that we do, lots of case studies. I think we should aspire to moving up that triangle, not right to the top with the RCTs, randomized control trials that you will have heard about kind of happening in the COVID, vaccines and those kinds of things. But I do think we should aspire to case control studies. So what that means is you take a set of data that is, say, for example, a set of patients that you've been working with who have received your hospital discharge service, then you get another set of data who were of a similar group of people matched that didn't get the service, and try and prove, I guess, that whether or not your service has led to, lower readmission rates, lower length of stays if there are readmissions occur, lower ambulance call outs and those kinds of things. So evidence is the one more thing I think we can do. We need to, as a sector, up our game on that, and I believe that we can. a good way in which we can do that, and I'm doing with an NHS trust at the minute, is by requesting the NHS shares their data with us and writing that into some of the agreements we have with them. The next one is around the opportunities that the formation of the integrated care systems create. So integrated care systems are partnerships of organisations that join up to plan and deliver services. They're more than just the merge of CCGs. I've heard people refer to them as that. I don't think that's fair. And I do think they represent a bit of a power shift away from necessarily commissioning colleagues and towards more influence from providers. They are a bit of a hook for supported housing, I think. They've been set up explicitly to include the voluntary sector, to include local authorities, to include NHS trusts, and to include housing organisations. So see those as an opportunity to enter into help and to get to kind of create better relationships with providers and commissioners. And then finally, and probably, I'm sure Shiraz would say most importantly, we have a stock of housing. Most of us do anyway, certainly at Look Ahead, we have lots of, we have a reasonably large housing stock for a supported housing provider. I think the question we're asking ourselves, and I would encourage others on the line to do, is are you using that in the most efficient way? Could some of the housing stock that you have be repurposed to meet the needs of the NHS? There really are lots of great opportunities out there to kind of work collaboratively with NHS colleagues to turn these kinds of services into crisis houses or forensic services or hospital discharge services. And the NHS really struggles for buildings, particularly based in the community. And so by working collaboratively and sort of keeping an eye on what your asset list is and making NHS colleagues aware, there are definitely opportunities there. Anyway, enough of my warbling. It would be great just to pass over to you, Shiraz, now, and any reflections on any of those three areas, or indeed anything, would be really, really useful.
Thank you, George. I was just thinking that it might be helpful to sort of pitch what we've been doing.
Yeah, right.
So, you know, in a way, what we've done is backwards. So nationally, there's been a big bit of interest in rehabilitation. So one of the drivers has been to reduce all of that locked rehab bed use. So this is hospital settings, normally in the private sector, where people end up living for years and years and years, often with schizophrenia, sometimes with personality disorder or complex trauma. And there's an acceptance that that shouldn't be happening, but the numbers haven't come down. If anything, the numbers might even have gone up a little bit. So you've got like 3,000 people living in these long stay wards, and effectively it's like the old asylums. And it's depressing because the whole point of getting rid of the asylums was that people should be living in the community. So as part of that, we started meeting with other areas, NHSE, and HousingLIN were saying to us we had these targets to meet. And what we learned was that actually in North East London, we don't have many people that live in those hospital settings. And that's very different to other places. So even our next door neighbours in North Central London, so Camden, Islington, Barnet, Enfield, Haringey, they've got loads of people that are living in out of area hospital settings. So what was different? And I think we then found out really that it's our close relationships with mental health supported accommodation that have facilitated that, and having different types of supported accommodation. So despite austerity and despite cutting lots of that provision, we have lost quite a bit over the last 10 years. We still have a mix of different types of self-contained property, some shared property, and also some residential care, which is a bit old-fashioned. You know, it's not quite nursing care, but it's about people having stuff provided for them rather than expecting them to develop their own independence again. So I think what's been powerful for us is the evidence we have that you can keep people outside a hospital setting, but you need to have a certain amount of supported accommodation to do so. And then I'll just mention quickly about the estates, just because I think that's been the biggest eye-opener for me, is that our conversation with you guys would always been a bit like, we're going to procure, you know, commissioning, procuring, what can you do for us? We're going to hold you to that contract. You're not doing a good enough job. It felt very adversarial. And I think what's interesting is actually talking to providers and saying, well, what have you got? What can you do? And that has opened up a whole range of opportunities. It's opened up sharing information in a way that I can't imagine we would have done 5 years ago. It would have felt like, no, that's our private, you know, corporate information. That's our business information. You can't have that. Into actually, if we don't share that information, neither side is going to benefit. And an example of that is a building that's not being used really well, that when I go and see it, I can picture, yes, that would be perfect for X population. And in fact, we're making steps to make some of that happen in one of the boroughs. if you don't get that information, you don't get that connection, my worry is that you'll sell some of your stock, or you'll just kind of feel like, well, you're going to use it just for regular housing, and that we're going to miss the opportunity to provide supported accommodation in those settings. So that's my tuppence worth.
Thanks both. That's really, really helpful. That's been really interesting to kind of hear. And yeah, I'm really looking forward to, Karina bringing in some of that kind of, okay, well, how can we help people, in their own homes as well through the kind of proactive kind of care program that you're presenting on. So I'll hand over to you. But in the meantime, I would encourage, I've got some questions written down here for George and Shiraz, but encourage others to put kind of Q&A questions in the Q&A box when they can. I'll hand over to you, Karina, in the meantime.
Thank you very much, Lewis. So I'm just going to share my slides here. Time always goes so slow, doesn't it, when you're trying to share your slides?
It does.
And hopefully that will be on full screen in a few seconds. Hasn't went full screen yet.
Yeah, I think it's just loading now. Yeah, great. That's perfect.
Well, good afternoon, and thank you very much for the invitation. So yes, I'm Karina Grimes. I'm currently Deputy Director in NHS England's national team in community services in the policy design implementation team. And what I'm planning to chat to you today, although community health services is very wide and varied and lots of portfolios, is to talk about proactive care. And people might have previously known it as anticipatory care. So going forward, we'll be referring it as proactive care. And really then, how does this link to the agenda we've just heard about from George and Louis and Shiraz, and how does this link to housing? So first of all, what is proactive care? So really the aim is to have that cultural change and to move from reactive, single disease-based fragmented care into just what we've heard, a more proactive, joined up, personalised approach for individuals, and to look at specific individuals with multiple long-term conditions, including frailty, and indeed mental health conditions are contained within that definition as well, and to deliver care in multidisciplinary teams in communities. So that's what it is. And this has been a commitment within the NHS long-term plan, with the aim to support individuals to age well, to enable people to be supported at home and remain as independent as possible, and to optimise their health. I'm just going to move myself on the screen here just so I can see the slides. That's great. And obviously the main aim here is to optimise health and well-being of people and enable people and communities to live there. And we want to do this by having an earlier and more proactive, holistic approach to care when the person's in their own home. And this should have the effect, if we look at the research and the data, to reduce avoidable unplanned care admissions that George has mentioned, by ensuring that people have access to planned health and care support in the community where they need it. And then this reduces the need for those more costly or upstream interventions and any avoidable exacerbations of ill health. So in terms of who are the cohorts, so looking at those at greater risk of unplanned hospital admissions, and again, George, you've mentioned about ambulance call-outs and A&E attendances, etc. So those with multiple long-term conditions, those with frailty, those experiencing health inequalities, and those currently using unplanned care for routine care unnecessarily. And I suppose going forward in our first cohort, we will be looking at particularly targeting particular populations. Sorry, my slides have just, there we are. So hopefully you can see a diagram on your screen at the minute.
Yeah, I can see that.
Okay. So this is quite an old diagram, but I quite like it. So our initial focus will be those with frailty. And I think it's good to represent how people with multiple long-term conditions and frailty, so organ failures, your dementias and cancers, how disease trajectories change. But ultimately, if we look at those with organ failure and dementia, how people will have episodes of cognitive and functional decline, and the same probably there will be episodes of decline, Shiraz, probably in terms of the mental health cohort that you were speaking of earlier. So what we're trying to do with proactive care is intervene earlier to extend the length of time that people have before these cognitive and functional declines, and to have that more proactive response when people do have that decline in their health, but obviously trying to maximise their well-being in the periods before and between. So how would I describe proactive care? There's 6 main components of the proactive care model, which is very much data-driven and is an evidence-based model. And really, the key thing is around that integration that people talked about earlier on today. So the 6 key components of the model. So the first is case identification, using population health management and data-driven approaches. How do we identify the cohort? And I think the key thing to mention is the need for clinical validation. So tools and algorithms have certainly a place to play, a part to play, but we certainly need to have that clinical validation and those conversations and those relationships. The second is holistic assessment. The third is ensuring that there's that personalised care and support planning. So what matters to the person, and again, very much linking into some of the other work around the personalised care and support planning process. The fourth component is multidisciplinary working, and again, working within and across multidisciplinary teams within that community setting. And number 5 is really looking at coordination of care, understanding the benefit of having that named coordinator. And within primary care, there are roles such as care coordinators, social care prescribers, or social prescribers, etc., that can support and coordinate that care. And I think, just as Shiraz had mentioned earlier around the relationships between providers and commissioners, the key role of relationships between the person and those who coordinate their care is crucial, and making sure that that trusting relationship can be certainly developed. And the 6th component really is looking at the interventions and supports. And that's very much where the housing agenda comes into play. So how are we going to deliver these 6 components? So the national team, in association with very high levels of engagement and stakeholder involvement, have developed a proactive care framework. Now, this framework is going through the final approval stages, and we hope that that's something that we can publish in the near future. So that's going through those stages just at the moment. So it'll be no surprise what it contains. So it gives you information on the cohort for proactive care. It outlines the proactive care model and the 6 components. It talks around how we can address health inequalities, looking at enablers such as partnership working, leadership, workforce and digital capabilities, and then governance, and then links with other programs and models of care. So in addition to the proactive care framework, there's also a proactive care interventions and support publication. And really, this is a guide to, so if we look at the 6 component model, this is really focusing on that 6th component and looking at interventions. So it really is going to help clinicians and other professionals deliver proactive care, provide a common approach to understanding what interventions and support are required. It's comprehensive, but it's not an exhaustive list, and it's suggestive rather than prescriptive. And it is something that will be continually updated in line with new best practice or evidence as that arises. So you will see, in terms of the interventions framework, it's divided into sort of 3 main components: the living well, the general support and targeted support. And general support, item number 7 there, support with issues relating to housing. So again, within that interventions and support document, it will go through housing considerations, signposting, and other relevant information for providers to enable them to provide that proactive care. So in terms of how can people get involved? Well, to support the implementation of proactive care, we've developed a community of practice. And this is an opportunity for all involved to come together, whether it's nationally, regionally, or at service level, to connect, to share knowledge, and to support collaboration. So we have designed the community of practice so that it aligns to each of the 6 components of the proactive care model. So tomorrow we are going to have our session on case identification. So we'll hear from colleagues in population health management and currency within the national teams, and we'll also hear from probably some of your colleagues in London in terms of some work they're doing in terms of rolling out proactive care. In May's session, we'll be looking at holistic assessment, personalised care and support planning in June, multidisciplinary working in July, coordinated care in August. And so in terms of housing, the interventions and support might be a really particularly session of interest for colleagues on the call this afternoon. So that's a whistle-stop tour, Lewis, of proactive care. We hope that there will be supporting documents launched in the near future, and we really would invite you to join us on our community of practice. Thank you.
Thanks so much, Karina. And yeah, thank you to all speakers. It's really inspiring to kind of hear different examples of what people are doing to kind of enable people to live well and kind of prevent unnecessarily use of kind of the NHS services. By focusing on keeping people well in the community. I know we've got some questions in the Q&A box, so I'll touch on those before I turn to the questions I've written down. But if we take the first one, which is from Harriet Nicol, so I'll read this out, but so she says, it's disappointing to hear earlier this month that the Department of Health and Social Care confirmed the 300 million funding announced in the Social Care White Paper in 2021 to integrate housing into local health and care strategies will now not be made available. So that's the Housing Transformation Grant. I would be keen to hear the panel's thoughts on this. It feels like those working in the sector are all on board and can see the benefits of housing and health collaboration. It's basically asking, how do we get buy-in when funding's cut? This only serves to demonstrate what a low priority it is considered. Bit of a kind of controversial question, but just want to kind of throw that out really for debate. I don't mind who kind of seeks to tackle that first.
Yeah, I'm happy to say that I think that having the amount of money you're spending in your local system is a really powerful way of getting people interested. Because as soon as you add up the cost to the whole system, and invariably people don't have total costs. So if you added up the cost of all mental health supported accommodation, all nursing care, all sheltered accommodation, and when you start adding it up and the numbers are astronomical, I think then the system certainly, for us, they have paid attention because they can see that it's a big ticket item. So then they're interested in how do you make the most of it? How do you support those placements? How do you make sure there's throughput? But it is depressing that it feels like there's less and less new investment. But I think there's still plenty of invest to save opportunities, especially if you're spending lots of money in mental health. If you're spending it on lots of out of area hospital placements, that's money that you can reinvest. But equally, I think even just in systems that are focusing on physical health or community health, in terms of hospice time, in terms of bed days, there's plenty of evidence that you can collect when you look at everything together, I think.
Yeah, thank you. Yeah, I was going to sort of, yeah, George, do you want to come in there?
Yeah, I do. Yeah, so I suppose the interesting point that Shiraz makes there, I think, which is so important, is just that there are cashable savings here. So you often hear grand economic arguments for this kind of work, or in lots of sort of areas of public service around, like, you know, if we invest in this reoffending scheme, we will save the public purse hundreds of millions of pounds. But people will often point to the fact, well, you ain't closing Brixton Prison as a result, are you? And that's often true. Whereas here, we know of mental health trusts that are buying bed and breakfasts, like, at great expense. We know of other trusts that are spending huge amounts of money on private hospitals and private providers. Like, these are real cashable savings that I genuinely think supported housing could do better, both at a small scale around bed and breakfasts, which are effectively crap hospital discharge services, let's be honest, which we can do better for the same price, or much bigger things like private providers doing forensic community services that we know that we could do better. So on the spectrum, there are lots of genuinely cashable savings. I wouldn't want to, I'm not good on the kind of big policy ticket stuff around huge government investments and why that hasn't happened. But I do think making the economic point is a good one, and continuing to make the evidence point and upping our game on evidence, as I said earlier, is the other thing I would say. When we don't have robust enough evidence, I think, to submit to Treasury on this stuff, and that's going to be a big focus for me in the next year or two.
Yeah, no, that's really helpful, and definitely something I picked up from your presentation around that need for evidence. And I think, you know, I think it's about providing not only kind of quantitative evidence, but also kind of evidence that speaks to kind of hearts and minds as well. I think it is that kind of change, like, you know, Karina, you mentioned that kind of culture change, using that phrase, creating a culture change by using kind of, you know, personal stories, so we can ensure that, yeah, you know, perhaps where we'd like the Housing Transformation Fund to come, that money to come back, but in terms of, you know, perhaps enabling that to happen, just, you know, hopefully trying to think about how that would impact the individual. So the stories of individuals as having a really important part of that. Karina, did you want to add anything on that, or are you happy for me to? I can move on to another question. Yeah, so it's a question I think is directed at you. So we've been talking about proactive care for some time. Now, are ICTs making it easier to deliver? Previously, there was lack of clarity, I think, in my view, about the NHS's role and the social care role. So yeah, so I guess what's the impact of integrated care? On proactive care.
So hopefully the launch of the framework and the supporting documents will provide that clarity. And it's certainly within community health services, we look at different portfolio areas. So it is one of our portfolio areas of focus, and we're working really closely with our regional colleagues in terms of the development of that. And the community of practice, I suppose, is one example on how we hope to work through some of the potential challenges and solutions together, so that we can actually deliver that. But any insights, really happy to, my email is on the slides, really happy for, I can't just find that lady, Sue's insights, yeah. Please do send them through. You might notice from my accent that I have only recently joined NHS England, so I have worked in health and social care in Northern Ireland for nearly 25 years. So any signposting, Sue, would be greatly appreciated. Thank you.
Thanks, Karina. And perhaps one from Matthews, perhaps directed at you, George. Just any advice you can give to providers of supported housing that want to begin partnership working with the, I think, NCS and
ICS is probably it'd be great to get Shiraz's view on that as well, but definitely start with where their gaps and their challenges and their issues are. So we know, for example, one of our South London trusts has got huge problems with bed and breakfast spend. So we specifically looked at the services the buildings that we have in that area, and thought about how we're using them and whether or not they could be kind of repurposed for that. So that was an obvious thing. We know that colleagues in another area have a huge forensic challenge. So we started to sort of show them around our forensic service that Shiraz knows well in East London. Start with where their problems are. I think people are fairly open. Like, I do think there's lots of cynicism around the kind of NHS changes and governments doing top-down changes. But I do think the birth of the ICSs, and again, I'd be really interested to hear Shiraz's view on this, have led to some slightly more grown-up conversations around these things, and people being a bit more willing to tell us where their big challenges are and where we think we can help. The other thing, I guess, is to get clear on is what your appetite for risk is as an organisation around working with the NHS. And really, my operational colleagues would have much more to say about this than me, but really robust sort of safeguarding and robust kind of processes and policies that allow you to work with medication and all that kind of stuff the NHS expects you to see. And then finally, in my experience, there's a higher bar around evidence. So again, I'll sound like a broken record, but make sure you do as much as you can on that front. But yeah, Shiraz, any advice for people wanting to work more closely with their NHS colleagues and their ICSs?
It's so tricky because each one has such a different setup and a different set of difficulties, and we've struggled to sort of get housing on the ICS radar and to get it on the agenda, but we're just about getting there. But that's partly by harassing the local authorities and harassing the senior board in your integrated care system, and then finding out what the NHS priorities are. I do think it makes a difference that you keep going and you keep trying to find out who's going to those meetings and questioning, is housing on that agenda at all? That's all housing. And I think population health, the whole kind of agenda around pollution and environment, I think it is there. It's all there for the taking, but it's how easily you can get that shoehorned in and to have a bit of leadership that's supporting you. And again, I think that, I wonder whether there's a way that people, if you're interested, how we can connect each other up within our different networks. So again, I've got networks of NHS colleagues that I'm sure will be really keen. So for example, I've got colleagues that are working in Luton, Bedfordshire as part of ELFT who struggle with providers. I keep saying there are providers out there who will move into that space, who will be interested. So it's how you join up these different people so that they can connect and actually be a little bit more creative. Otherwise, I think it's an arbitrary conversation, and the ICBs are trying to prioritize, aren't they?
Thanks both. That's really helpful. Hopefully that's been helpful to you as well, Emma. I've got a question just for Karina. I wonder if I could bring you in here. Just wondered, what you kind of see as some of the biggest kind of challenges and barriers to implementing the proactive care programme. I'm sure those have been kind of discussed, but any thoughts on that?
I think with every barrier challenge, it gives you opportunity. And I think it's around identifying your cohorts and the multidisciplinary team working and how you bring people together to deliver those types of solutions. So for me, I think one thing that could be perceived as the biggest barrier would be the biggest strength. It's around those relationships of people and getting people to work together. Mm-hmm. I think the evidence and people intuitively feel proactive care is the right thing to do. And if you think about care and support from our own individual perspective, or for those who are important to ourselves, care close to home in a preventative way, in a joint up way, is the care that we would want. So I think whilst there will be challenges in new ways of working and sort of transformation in terms of workforce, I think the benefits to people, whether that's patients, whether that's you as a staff member, and then the benefits to the system will help overcome any of those challenges and barriers. Because ultimately, I think it's going to help, as I say, outcomes for people, but also staff morale. And I suppose just listening to George and Shiraz and Louis earlier, delivering care the way you want it gives you job satisfaction. And I think if we look at the benefits, that will certainly help steer our way through any of those potential challenges in the next while.
Thanks. That's really, really helpful. All about kind of working together and focusing on the benefits for the individual, really. Yeah, that's really helpful. George and Shiraz, I wonder whether, obviously we talked about kind of the benefits of kind of, you touched on that your research essentially was looking at very light touch, looked at some of the reduce costs for the NHS, I guess, in comparison to some of the alternatives of kind of supported housing. But I wonder whether you'd be able to kind of just touch on some of the benefits to the individual in any kind of stories that you've got around people that have actually, you know, moved into some of the preventative services that you've got. That would be really nice to kind of hear some individual kind of case studies, or any case studies you can kind of share with us offline would be fab as well.
Yeah, and I think it's a really, really useful tool, and it's something we go on and on about. So when we provide sort of consultation to other areas, we say the numbers are fine, but clinicians care about people. And if you can't show that stepping down and stepping through is helpful, it's not going to win people over. And I think years back, there was a young woman who had been living in a private hospital. She was our last one, funded by Hackney, and she'd been there for over 10 years, and she was 24. So you can imagine that someone from their mid-teens, having lived in a hospital setting, everyone had a lot of clinical pessimism about whether anything would change. And we brought her back, and we have an accommodation provider that she's been in the same project now for over 9 years. And we, you know, she's living in the community, and she's not, you know, she's still very unwell, and she still struggles, and she's got a lot of support on site, but she doesn't have anything like 2-to-1 or 3-to-1. She's living in her own self-contained flat with staff downstairs. And I think we remind people of that story, remind people, we have photos when she goes to get her hair done and get her nails done, which she loves, and that she's accessing the community the most that she can. And we definitely wheel that story out a lot. And then we've also got some videos that we made. So my colleague Lucy, who's an occupational therapist, they presented it at their conference. And again, their stories of people talking about stepping down and how positive it was for them. Not that we came along and cut their support and left them, but talking about how lovely it was to have their own front door, how lovely it was to be able to cook a meal in their own kitchen that they wanted. So I think definitely all those examples and stories help us flesh out the numbers.
Thank you. That's really, really helpful. And yeah, inspiring to hear as well. We've got kind of a comment from Rob Hepworth as well in the Q&A box. I won't read the full thing out, but essentially he's kind of saying, you know, we've kind of got multiple kind of competing cohorts of people that require specialist accommodation, along with kind of, you know, really high demand for kind of general needs housing stock, particularly when, you know, local authorities have no stock. So I guess he's kind of asking more of a kind of comment, but, you know, how do we kind of deal with that kind of those sort of competing challenges? I know, George, you sort of mentioned that we do have, you know, we've got a lot of housing, but it does seem, you know, speaking to kind of local authority colleagues, that there are lots of kind of pressures at the moment around who to house. So I wonder whether there's any comments that you
yeah, and I should say we're a sort of specialist housing association that focuses purely on supported accommodation. So I'm very mindful that my local authority colleagues have a huge general needs housing population that they're working alongside too, and that's not something that we as an organisation, you know, do. So I check my kind of privileged position in that regard. I'm very mindful of that. I don't think we have a sort of way we prioritize what kind of service we do. It's slightly more opportunistic than that, I think. So in some instances it's about where we have stock and what the need of our colleagues are, be them from the local authority, social care, or the NHS in that particular area. Obviously we use the kind of models that we have sort of pre-packaged around hospital discharge, forensic, crisis care, and learning disability services we haven't mentioned at all today. Yes, it's a very good point, and I look at it through a slightly blinkered lens, which is fair enough. Shiraz, you were going to come in, I think.
Well, it's one of my favorite topics in the whole world, which is tragic, isn't it? It's about the placement review, and we're obsessed with the clinically led review of that placement, and we're really passionate about the fact that when someone has done what they're going to do in that particular supported setting, they need to move on or reduce the level of support. And I think often what happens is a package of care is opened by the local authority and it never gets reviewed. And people end up a little bit stuck in this kind of limbo area because the crisis is over, the problem is gone. And then you need someone to go in and actually think about, does this person in any setting, whether it's physical health, mental health, learning disabilities, do they actually need that level of support or input anymore? And I think when you can demonstrate throughput as a result, that makes a big difference to whoever's holding the funds. And then you can say, well, if we had a quota, if there were, we've currently got 8 spaces a year for Hackney, Tower Hamlet's got 35. So they are, set aside for people coming from our mental health pathway, and what a difference that makes. It absolutely speaks to what Rob's saying about being silted up, because if there's no way out and there's nowhere for people to go, then you just end up with a bigger portfolio. Whereas a good chunk of people, not everyone, a good chunk of people will be able to step back into independent at some point.
Thank you, and yeah, thanks both for tackling a kind of tricky comment and question at the moment. So thank you. We've got a couple of other questions before we close. I've got one from Sue Wetton. So they're really keen to grow their supported housing for people with complex needs in Derbyshire. But our providers are finding recruitment and retention of skilled staff a massive barrier, which I think is a national issue. But our providers in other areas of the country experiencing this as a major barrier to growth of utilising a progression model towards independent living. I don't know, George, whether you want to kind of touch on any kind of experiences that you are having with recruitment and retention of staff at the moment.
It's challenging. I'm not going to beat around the bush.
No.
we have experienced some big challenges, as have other colleagues, as pointed out by our colleague from Derbyshire, as has the NHS, right? I don't know about your team, Shiraz, but I certainly know chatting to a psychiatrist at Camden and Islington, he was just like, I haven't got any nurses in my team. Like, there just aren't any. So yes, it's a big problem. There are a couple of things that we're doing to try and I don't claim that this will solve the problem overnight, or indeed solve the whole problem. Lining up some work with clinical psychology trainees who have year-long placements that are 3 to 4 days a week. And particularly where we are in London, there's quite a lot of universities that offer that, and that's going to be a kind of potential pipeline for staff. Looking at kind of putting positions into when we bid on contracts, looking at putting more positions in that allow support workers to get promoted, so we don't into sort of senior support worker or specialist support worker roles. The other thing we do find, and I think this is fascinating, to sing Shiraz and his colleagues' praises whilst he's on the line, our staff love opportunities to work alongside closely with psychiatrists, psychologists, nurses within the NHS. And actually, we find the closer our services are to clinical services, the lower the turnover is within those services. They're interesting services, therefore, but they're also, I think there are lots more organic learning opportunities there, and I do think that makes a big difference. That someone dropped a point in the chat around, do you find it's easier? I can't remember exactly what they said, but it was a really good point around. It's easier to run services where the partner, or do your services, do look at services require kind of very good relationships with providers? Mm-hmm. Yes, particularly the more specialist ones. So the more specialist it gets, we ain't going to go set up a forensic service somewhere where we're not really, have a very strong relationship with the community forensics team. Perhaps a sort of lower level hospital discharge service with medically fit for discharge people we might be a bit more comfortable with, but the more specialist, the closer we would want them to be.
Thank you. Karina, is there anything from kind of NHS perspective around kind of recruitment and retention? It's kind of obviously a really big topic at the moment. Anything that's, you kind of touched on earlier around the proactive care model, kind of potentially kind of creating that better, I guess, sense of achievement, or within kind of the workplace. Is there anything, anything you kind of want to share?
Yeah, nothing specific on that particular topic, but I suppose we are looking at the likes of Fuller and those integrated neighbourhood teams and how that will work. So yeah, I suppose we'll be taking our cues from that and from our colleagues in workforce then as well.
Got just a couple of other questions here. So we've got, there's always nervousness about discharging to the community and a fear that mental health services will disappear once people are rehoused due to capacity issues, what can housing and local authorities do to encourage mental health services to remain involved? I guess that's probably more targeted towards kind of George and Shiraz, but Karina, do feel.
I was hoping you might take that one, Shiraz.
Well, I mean, I think it goes back to your point about where there's a better relationship, then I do think it's easier. And I would agree with Rebecca's point, and we hear it all over the place, that the provider feels that as soon as a person's left the hospital, usually, then they've lost all interest in that person and they're left to get on with it. And I think it's hard because where we're working at the moment, we view all of that provider stuff as part of our extended team. And in the same way that we wouldn't just leave another bit of our team, unattended to if they're struggling, we kind of feel like if we don't support our colleagues and providers, then the whole thing's going to fall apart and the person's going to end up in hospital and then we're back to square one. So it is about, is anyone in that system able to think like that, or is it just firefighting all the time? And I do fear that in those systems where they're just firefighting, no one's got the space to think, well, hang on, maybe we even need like a monthly visit or a regular review or someone to go and visit the projects to be a bit more preventative rather than waiting for things to go wrong. And so we meet with our big block providers monthly, 2 monthly, and go through any lists of issues, and we will kind of sort of mediate between other teams. So not everybody in those places is under our team, but if they're struggling to get a response, if they're struggling to get any help, we can try and push that from our end. So it's finding your NHS friend who can sort of mediate that and, help move things along for you.
Brill, thank you. That's really helpful to have that answered. I guess that is slightly linked to that kind of what Karina you're talking about in terms of proactive care. In keeping people involved, it's about kind of being proactive and enabling people to remain in their own homes for as long as possible. So yeah, really great.
And just tying in with what Gerard said in terms of the importance of review, and it's not a binary thing, or it's around what's the need for the person, what do they feel comfortable with. So some people might need more frequent reviews, and it's just respecting that and building that flexibility into the model.
Brill, thank you. We've got some other comments, but just I think one more kind of question from David Black. So I haven't fully read it, but I will read it out right now. So is anybody at NHS England centrally monitoring the consistency of the various ICSs and ICBs or ICBs and how they engage and involve those working on the front line and housing third sector colleagues? As someone who felt engaged and involved with my local CCG, I'm struggling to get any sense out of my local North, I think NE and NC, I don't know what it stands for, apologies, IPS. I don't know whether Karina you're able to comment on that at all.
Not in that particular instance, but I suppose what I would say is, again, it's back to relationships. So it's less about the monitoring, more understanding what our national support can be. And there is, the planning guidance, and there is the planning returns. So there certainly is ways to begin to capture sort of key policy areas that's outlined in the planning guidance, and then how our colleagues in ICBs are working towards those directions set.
Okay, thank you. Okay, I'm seeing some kind of comments, but I'll let people kind of read those in their discretion rather than kind of ask them to the speakers. I think we've had a really interesting kind of Q&A session. So I will start to draw our session to the close. So just really want to thank everybody so much for contributing to today's session. It's really great to have you on board, and just to kind of, in terms of our next kind of happy hour kind of sessions that we've got coming up. So we've got one next week on the 11th at 4 p.m. as well. This will be also chaired by me, which is nice. So it'll be on some research that we were part of a research team with the University of York and University of Bristol on housing for people with learning disabilities. So that was looking specifically at people with kind of mild to moderate learning disabilities and their experience of renting their own homes. So the research will be kind of launched at our Happy Hour next week, along with some presentations from Learning Disability England, and hopefully a Housing Friday as well. Thank you very much again to all our speakers today. It's really great to be here with you, and have a nice evening, everyone. Cheers.